we'll move on to our next session. This is an interesting one. So we know till a few years ago, neoadjuvant and adjuvant treatment was based on only chemotherapy and radiotherapy. But newer trials and newer data has shown that addition of targeted therapy, novel agents, and immunotherapy has dramatically improved the outcome. And we've got some promising results which has come up very recently. And to enlighten us on that, we have none other than Dr. T. Raja. Dr. T. Raja, sir, is a senior medical oncologist and director of medical oncology, Apollo Cancer Center, Chennai. Sir has got more than 26 years of experience in the field of oncology. He's the head of the department and he's the head of the DNB Medical Oncology Program, Apollo Hospital, Chennai. The distinguished clinical tutor in medical oncology. Sir is an active member of major oncology groups in the country, including ISMPO, ICON, and ISO. Over to you, sir.
Thank you, Dr. Anish, so much for your very kind invitation. Dr. Animesh, my slides are visible and audible, correct?
Yes, sir.
Thank you. I thank the organizers for this kind invite, and I'm happy to be with you all. And thanks, Dr. Animesh, for giving me this interesting topic, newer paradigm of neoadjuvant and adjuvant treatment in resected or resectable lung cancer. So I'll begin with a couple of slides from Professor Goldstraw's paper in Thoracic Oncology in 2016, where he shows that 5-year overall survival outcomes decrease with increasing stage in resectable lung cancer. As you look at the stage, there is a significant decline as the stage progresses, and the 5-year overall survival dramatically drops to 60 immediately at stage 1B, and in 2A it's already 60, and by the time you cross 3B, it is 26%. This is true not only for clinical stage, as he has shown, and he also shows that pathological stage, and these are the survival curve for pathological stages. So there is definitely plenty of room for improvement with surgery alone. That's basically because in spite of surgery, there is plenty of recurrence rate. In early lung cancer, definitely the recurrence rates are high. And if you look at stage 2, already there is a recurrence rate of 62%, and stage 3, we have a recurrence rate of 76%. So we need to consider what other factors we can do while we want to treat these patients of early lung cancer. How do we improve them? Obviously, the recurrence rate worries us, and something special, subset CNS recurrence, and then we look at how do we improve their outcome with either an adjuvant effort or a neoadjuvant effort. But whenever we put on these efforts, we have to look at what is the DFS achieved with these options, and finally, what is the overall survival achieved with such interventions. And then we need to look at safety of such interventions, and finally, the quality of life for the patients. That's how you consider to choose these options. But interestingly, 26, 27 years ago, this was not new. The whole effort of perioperative management in and around surgery was on even earlier on. Then this is a paper by Dr. Roth in 1994, which showed that perioperative chemotherapy in stage 3A selectively would be better than surgery alone. So that was a paper that was as old as 26, 27 years ago. But then subsequently, number of adjuvant trials appeared. One of the most important one is the ANITA study. It showed that adjuvant chemotherapy in a broad range of stage 1B to 3A non-small cell lung cancer would give an advantage in DFS and in OS by only 5%. 5-year survival advantage, both DFS and OS, only addition of 5%. And a subsequent LACE meta-analysis, which include 5 trials, including the ANITA trial, would show the 5-year overall survival was only beneficial by around 5.4%. And this was again, retrospectively reanalyzed by Dr. Krish in JCO 2017, the 5-year overall survival and the retrospective analysis of absolute benefit of chemotherapy. Here is where you see this. If you look at the absolute benefit in purple, you hardly see that in 1B, but in stage 2, you start seeing that the absolute benefit appears anywhere between 10 to 15%. And in stage 3, you see the absolute benefit of 15 to 20% plus. So that's where the real benefit lies with adjuvant chemotherapy. This is another interesting paper by Dr. Brandt in 2019, where there is a retrospective propensity matched analysis which showed that neo-adjuvant versus adjuvant, the DFS and OS are almost the same. The survival curves are superimposable, meaning that neo-adjuvant is equal to adjuvant, adjuvant is equal to neo-adjuvant. But not not immediately, because if you look at these data carefully, neo-adjuvant effort, what happens is 78 to 90% of the patients were able to receive full dose of chemotherapy and all cycles of chemotherapy, whereas in the adjuvant effort, you can see only 60 to 70% of the patient would receive full dose or all the cycle. And strangely, the grade 3 side effects were more in the adjuvant setting, probably because of post-operative recovery and neo-adjuvant or fresh patients. That could be the explanation. So now look at the adjuvant efforts with the tyrosine kinase inhibitors, wherever there is a receptor-driven disease, and taking the EGFR as an example, EGFR TKIs is adjuvant therapy. There has been numerous trials with both erlotinib and also with gefitinib. They have all consistently shown one thing, DFS benefit, but none of them later on matured to show an overall survival benefit. And for example, this is the Radiant trial for adjuvant erlotinib. When we looked at the intent to treat population, all comers, you would see that the DFS showed no benefit, but in EGFR mutant subgroup, you would see that the DFS is slightly better at 46 months as compared to 28 months with the placebo. And this is the adjuvant or the CTGONG trial with adjuvant gefitinib in patients with stage 2 to stage 3A gefitinib. And in patients who are EGFR mutant, you would see the DFS benefit of the hazard ratio of 0.6. This is the most important trial, ADAURA, that we are all looking at now. And this was, the early results were available from 2018, and it was well published in 2020. Phase 3 double-blind study of adjuvant osimertinib, and these are the DFS curve. The ADAURA shows there is a significant improvement in the DFS, both in the overall population of stage 1B to 3A and in the primary population of stage 2 and 3A. If you look at all these individual subgroups of stage, you see there is a consistent 2-year DFS advantage. And if you look at 1B, the DFS advantage hazard ratio is 0.39, stage 2 0.17, and stage 3A, the DFS advantage was 0.12, which is very, very impressive. And this trial also shows that the recurrences were decreased with osimertinib. If you look at the recurrences with placebo, it was 46%, and the recurrences with osimertinib was only 11%. Again, the number of systemic recurrences was much less with osimertinib as compared to the placebo. So the total number of recurrences and the systemic recurrences were reduced. Again, particularly looking at the CNS recurrence in the adjuvant CTGONG trial, 27% of all the recurrences had CNS involvement, and in the adjuvant Radiant trial, 37% of all recurrences had CNS involvement. We know earlier that osimertinib has got a better CNS penetration because of his blood-brain barrier penetration, so one would expect that this would do well in CNS disease, and this is already shown with the metastatic setting, the efficacy of osimertinib in CNS progression. It was found that 1/3 of patients as compared to placebo would progress in the CNS whenever they were put on osimertinib. So the ADAURA trial was also showing that the CNS recurrence rate was very low with the adjuvant. In the adjuvant setting, the CNS recurrence is only 1% as compared to 10% for the placebo. The CNS deficit DFS, disease-free survival, is also beneficial in the ADAURA trial. And the time of publication, it was shown that the DFS was not reached and the hazard ratio was 0.18. Consistent that the CNS benefit is very, very good with osimertinib. So based on these trial data, FDA in 2020 would approve osimertinib for adjuvant therapy after tumor resection in patients who have the EGFR mutations, particularly the exon 19 and the exon 21 L85R mutation. And so now we look at what are the adjuvant efforts with immune checkpoint inhibitors. And a number of phase 3 trials are on with as adjuvant immune checkpoint inhibitor monotherapy in resected patients with pembrolizumab, with nivolumab, and with durvalumab. and with atezolizumab. The atezolizumab data, IMpower 010, was presented last year in the ASCO, and these are the results for adjuvant atezolizumab in stage 1B to 3A. And that too, these patients, whenever chemotherapy is indicated, have already received chemotherapy and then adjuvant atezolizumab. Post that, and this is the DFS benefit that you see. The DFS is 42 months as compared to 35 months with basic supportive care. And this is for all stage 2 to 3A patients, which was the primary endpoint. But again, if you look at the DFS for patients who have a PDL1 of at least more than 1%, you see that the DFS is not reached at the time of publication with the hazard ratio of 0.66. And therefore, the DFS benefit is actually seen across all subgroup with adjuvant atezolizumab, but they are very amplified in stage 2 to 3A, and whenever they have a PDL1 of more than or equal to 1%. And if you see the survival curve in the intent to treat population, all comers, they are closer, but the benefit is seen to the tune of 12% delta here in the patients who have a PDL1 of at least 1%. And if you look at the subgroup analysis with the adjuvant atezolizumab trial, you see certain striking points. In patients who have an EGFR mutation, there is no benefit. In patients who had an ALK mutation, adjuvant atezolizumab did not show a benefit. But with increasing PDL1, you see that there is a consistently increasing or improving benefit. So the summary for the 010 trial was that significantly improved DFS with atezolizumab given after surgery, after cisplatin chemotherapy, but it was greatest for patients with high PDL1, particularly for PDL1 more than 50%, with a hazard ratio of 0.44. What about neo-adjuvant efforts with immune checkpoint inhibitors? And this is the rationale for neo-adjuvant immune therapy. It was seen that neo-adjuvant immune checkpoint inhibitors given before surgery would demonstrate that post-surgery you would see that there is a systemic anti-tumor response due to the activated tumor T cells that are still there in the specimen. And this proof of concept was seen early on with the nivolumab data. You see that there is a clinical and radiological response with nivolumab, and again these are the waterfall plots for the responses, and you see that in biopsy before nivolumab and biopsy after nivolumab, that you see the response and you see the T cell infiltration. Based on this pathological response, where then subdivided as is minor, moderate, and major pathological response, and these then turned out to be surrogate endpoints for neo-adjuvant trials with immune checkpoint inhibitors. These are the data for the phase 2 neo-adjuvant nivolumab, and this is the neo-adjuvant atezolizumab, again a phase 2 impressive waterfall plots, and the pathological response rate with nivolumab was actually 20 to 25%, whereas with atezolizumab you would see a neo-adjuvant PCR rate of 21%, and this is neo-adjuvant atezolizumab plus chemotherapy, and these are the waterfall plot, and you see a major pathological response. You would see at least in some set of 90% is what is seen when you combine atezo plus, but these are all phase 2 trials, and this is phase 2 NADIM trial, neo-adjuvant nivolumab plus chemotherapy. Again, major pathological responses, 83%, and a PathCR of 63%. Very, very impressive numbers. And these are the number of trials that are on, wherein neo-adjuvant immune checkpoint inhibitors are on. But the one that is already mature and published is the CheckMate 816 data, wherein a neo-adjuvant nivolumab this is a phase 3 randomized trial, neo-adjuvant nivolumab plus platinum, and this was presented in last year ASCO and the AACR, and this is for stage 1B to 3A resectable patient where nivolumab plus platinum doublet chemotherapy, and post that you would operate within 6 months of completion of 3 cycles of chemotherapy, and then followed by adjuvant immune therapy depending on. And these are the results. The primary endpoints were PathCR rate, and you see that the PathCR with Nivo and CT PathCR is 24%. and particularly in completely resectable patients, the PathCR of around 30%. This is something like what you see in breast cancer, in that too in HER2-driven disease or in triple negative, you see PathCRs of 30 to 50%. That's what you see with nivolumab plus chemotherapy in non-small cell lung cancer. But if you look at the subgroup analysis, this is what we learn from the CheckMate 816. Across all stages, 1B, 3A, you see the benefit. Across squamous, non-squamous, you see the benefit. Across all PDL1 spectrum, in neoadjuvant settings, strangely, you see the benefit. Even if it's PDL1 low, you see that there is benefit. TMB high or low, you see the benefit. That is something good to learn. But what you also see is that these patients have not been analyzed for presence of driver mutation. So we do not know the answer if these patients have driver mutations, whether neoadjuvant immune therapy will be as beneficial or not. We don't know the answer to that question. And this is the pathological regression according to stage. So the response is as good in across all the stage. This is also something very good to learn from the 816. And again, something more interesting, these pathological responses were followed up based on whether these patients have circulating tumor DNA, ctDNA clearance or not. So in patients who have circulating DNA clearance, you see that the PathCR were as high as 56%. So that is something very, very stunning. And you also see that the PathCRs were very, very good in patients with a ctDNA clearance, and there were not good PathCR without ctDNA clearance. This is again something relevant, whether this is compulsory for us to incorporate in all neoadjuvant immune checkpoint trials or not. We'll come to that later. The summary of 816 trial is as follows, that the primary endpoint of PCR with the addition of nivolumab to neoadjuvant chemotherapy has been met. The primary endpoint has been met, and the PCR benefit is across all subsets, except, of course, the biomarker-driven disease. But you can't ignore the biomarkers, because in lung cancer, biomarkers are diagnostic, prognostic, predictive. So how can you design anything without biomarker consideration? So we need to take that into our considerations. So therefore, some of the trials are on. This is the neo-adjuvant trial, in which phase 3 trial is on, wherein there are patients with EGFR mutant disease, exon 19 and the exon 21, where you see that osimertinib neoadjuvant, osimertinib alone, osimertinib plus chemotherapy, or placebo plus chemotherapy followed by surgery. This will be a very interesting trial to look at. The ADURA 2 is another interesting trial wherein a select population of stage 1A alone is taken, and these patients should be demonstrated to have EGFR mutation, and then again they should have lymphovascular invasion, and based on that, these patients are put on osimertinib. And again, this is very exclusive, non-squamous, non-small cell lung cancer. So let's see whether this fully selected group will show the best possible outcome with osimertinib or not. That is something to be seen. So this trial will tell us something, whether the osimertinib is going to be beneficial in early disease, even among the resectable disease, versus a slightly bigger stage among the resectable disease. That's the take home, which probably will be available with this particular trial. And this is another very interesting trial that's ongoing, that's known as LCMC4, wherein available, actionable, all drivers are tested and the patients are identified, and these patients are treated in the neoadjuvant setting with all those interventions, with immune checkpoint inhibitors, with targeted therapy. And this trial is popularly called as the leader neoadjuvant screening trial. Is kind of a basket trial wherein each patient is treated according to their mutations that are seen, and then the results, of course, we are eagerly waiting. This is one such patient, neoadjuvant alectinib in patients who have an ALK translocation. You can see the clinical and radiological response, and then you see that VAT surgery, and you have a 15% residual viable tumor. That is something like a major path response with the ALK inhibition.
Sir, 2 minutes left, sir.
Yeah. Last Kashish. So therefore, now the circle has come to whether we have to compulsorily use ctDNA measurements, and whether that's going to predict the occurrence of pathological complete response in the perioperative immune checkpoint inhibitor. So therefore, coming to the topic that Animesh has given to me, the newer paradigm of neoadjuvant and adjuvant treatment in resected lung cancer, of course, the paradigm has shifted. It's not anymore surgery alone. There is going to be adjuvant therapy and there's going to be neoadjuvant therapy. Earlier, it was very black and white. You have one or two options. Chemotherapy was the only option, but thankfully, with all these things, now these options have become very colorful. So that's the paradigm shift, and thank you so much for your attention.
Thank you. Thank you very much, sir, for your elaborate and extensive talk. I'd like to have one question. So, sir, whenever we use a novel agent for any newer indication, in India, we depend on DCGI approval. So, have any immunotherapy or novel agent in adjuvant or neoadjuvant setting have got a DCGI approval? Just a query.
Thanks, Animesh. I just want to say that I believe that we follow the most of us would copy the FDA approval for our discussion, and patients would be able to take it. Number one, and these agents are already available. These are the other way around. These agents are approved drug therapeutic options which are available for a different stage and a different setting. So if you counsel, and if there is one major body approval, that should not be a problem in counseling this to the patient. But on the other hand, to specifically answer your question, whether there is a DCGI approval or not, I just want to beg that I may not be knowing the right answer, but the osimertinib post-surgery adjuvant probably has got a DCGI approval. I am not aware whether nivolumab or atezolizumab has been approved either in the adjuvant or neoadjuvant setting. I'm not yet aware of that, Dr. Animesh.
Thank you. Thank you very much, sir.